Smell by Alice Cusick, MD. It was just a whiff, a few molecules of scent in the air. Inwardly, I shook my head and tried to concentrate on what the patient's wife was saying. I blinked. There it was again. The smell was musty and sour, but the patient was as clean and tidy as he always was, sitting in his wheelchair with his wife next to him. He didn't look much different than the week before or the week before that. As I examined him, I found no unwashed hair or unbrushed teeth. There were no open wound, no stale diaper. The odor was a faint whisper without an obvious source. My heart sank. I had known him for a few years, shepherding this elderly man and his wife through the aftermath of lymphoma treatments. To be honest, when I first met him, I found him irascible and even a bit difficult as he regaled me during each visit with the same stories of perceived mistreatment at another institution. But then, his mild anemia steadily worsened and led to a diagnosis of therapy-related acute leukemia. He didn't want any treatment. We had weighty discussions about his mortality, and his irascibility melted into vulnerability. Suddenly, his edges softened, and I found our bond. Discussing death had removed his outer shell, and I discovered I really liked the man underneath. He then began coming to see me frequently to get transfusions to keep him from bleeding, to give him enough energy to walk around his house and make brief trips out with his wife. She was the rock, the one who drove and cooked and kept him happy. During these office visits, the three of us laughed often, even as we discussed his decline and inevitable end. They both wanted him at home. He adamantly did not want to die in the hospital. One day they brought photographs of his younger self. The youth and athleticism in those photos starkly contrasted with the wisp of the man before me. After so many visits, often talking about things other than his health, I thought I knew this man reasonably well. The photos gave life to his descriptions of his past experiences, and with those images in my mind, his story became fuller to me, gaps filled in and given flesh. They had previously refused any help at home because his wife and family were capable. We agreed that when transfusions were no longer helpful, we would stop them and hospice would be called. The smell hung in the air. The clock ticked. The cogs fell into place. "It's time," I said. Arrangements were made. His wife told me he died a few days later in the afternoon after a nurse had put clean sheets on his bed. It was quiet and at home, just like he wanted. I hung up the phone with her and felt unsettled. The social worker and nurse who had seen him in clinic with me had given me puzzled looks that day when I asked about the patient's smell. His passing so shortly after our visit confirmed what I had sensed that day but did not want to confront. I had smelled his impending death. This incident haunted me. Had I become like Oscar, the cat in the nursing home that visits residents who die a short time later? Did I suddenly have a gift? Could I float through the hospital wards and smell the future? Or maybe I could only smell inevitability. My rational mind told me it was the smell of experience. Wires crossed in my brain like the person with synesthesia that smells lilacs when listening to Chopin. The knowledge that this man in front of me was close to dying translated into a smell instead of a thought. 25 years in this field, 25 years of catching a flicker of pain in the eyes, the faint jaundice in the skin, of really knowing patients, of seeing photos of their younger selves, their lives before cancer, as they faced death with incredible grace. Memory upon memory of patient after patient stacked in my brain, thinly sliced into a scent. That odor sank deep into my brain where I buried it. Occasionally, flickers of a flashback would surface and make me uneasy all over again. That smell had come to me unbidden and put cracks in my vision of the sphere of my oncology life. Maybe it was this lack of control that bothered me, this fear of not being able to even understand my own senses. What else about myself, about my patients, about medicine itself did I not comprehend? I came to resent how this odor had invaded my orderly world, shifting my memory of a patient to the memory of a smell that was real and not real. I came to realize this experience bothered me because it made that last clinic visit about me as a person, not me the oncologist. two pieces of myself I have long fought to keep separated. This odor had interfered with my usual way of grieving for a patient I had come to know deeply. I didn't want my memory of him to be colored by a personal experience I couldn't explain. Over time, I stopped trying to understand with certainty what happened that day. I decided to hold on to the mystical quality of that odor as a sign of the profound connection I had to this patient, to another human being. Enveloping this experience with words has helped me to hold on to its beautiful, unsettling nature, remembering how connecting to others is how we get through this life and this job. Fortunately, I have not smelled death since.
Welcome back to JCO's Cancer Stories, the Art of Oncology. This ASCO podcast features intimate narratives and perspectives from authors exploring their experiences in oncology. I'm your host, Mikkael Sekeres. I'm Professor of Medicine and Chief of the Division of Hematology at the Sylvester Comprehensive Cancer Center, University of Miami. Joining us today is Alice Cusick, Hematology Section Chief at the Veterans Affairs Ann Arbor Health System and Assistant Professor at the University of Michigan Division of Hematology and Oncology, to discuss her Journal of Clinical Oncology article, Smell. Alice, thank you for contributing to Journal of Clinical Oncology and for joining us to discuss your article.
Thank you so much for having me, Mikkael. Appreciate it.
It's really a pleasure, and as usual, Alice and I discussed this beforehand and agreed to call each other by first names. I always love to hear your story first. Can you tell us about yourself? Where are you from? And walk us through your career if you could.
I'm a Midwesterner. Grew up in Iowa and Illinois and went to a small college in Illinois, played basketball, Division III, and was an English literature major. I took one science class and was going to be an English professor. And then my father's a physician my senior year, and realized I don't think I could spend all my time in a library. I didn't feel like I was helping anyone. And so I talked to my dad, and he said, yeah, I think you could be a doctor. So I thought I would help people by being a physician. So I moved to Iowa City and spent 2 years working in a lab and doing science classes, and took the MCAT, which was the first year they had the essay on there, and I rocked that. That was my highest score. Got into the University of Iowa and then went on to residency and fellowship at the University of Wisconsin, just in hematology. I didn't do solid tumors. And then went on, spent a couple of years there, worked in Pennsylvania in more like a group practice, and then came back to academics at the University of Michigan about 10 years ago. And then 5 years ago, I became the Hematology Section Chief at the VA in Ann Arbor. So I work there full time now.
I love that story. I served on the admissions committee at Cleveland Clinic in Case Western when I was also a Midwesterner for 18 years. And I always wondered if instead of searching for science majors, we should be searching for English majors, because I think there's a core element of medicine that is actually storytelling.
Oh, very much so. My father was a country doctor for many, many years in rural Iowa in the 50s and 60s. So he did house calls, and he talked about how you really got to know people by going to their house. And I'll never forget the first time that I did a true history and physical. I think I was maybe a second year medical student. And I was telling him, oh, I'm so excited. I'm going to do my first history and physical. And he said, Alice, don't talk to them about medicine right away or about their problems right away. Talk about something else. Get to know them. He goes, you know about sports. Talk about sports. I said, Dad, that's called establishing rapport. That's what they had taught us. But it was intuitive to him. I never forget that. He just said, their story is important, and how they live and where they live and who they live with is so important. It really helps you figure out their medical issues as well. And I've always tried to carry that through.
It's funny what we glean from our parents. My dad was a journalist for the Providence Journal Bulletin. He was a reporter for a couple of decades. And I almost feel like some of what I'm doing is acting as a reporter. It's my job to get the story and get the story right and solicit enough details from a patient that I really have a sense that I'm with them on the journey of their illness so I can understand it completely.
Oh, very much so. And that's one of the things I really harp about the fellows, because sometimes I remember more of the social history than I do sometimes the medical history when I'm seeing a patient. And I remind them, you need to know who they live with and how they live. It helps you take care of them.
Well, and that must be particularly germane with your patient population. When I was a medical student, my first rotation on internal medicine was at the Philadelphia VA, and it's actually what convinced me to specialize within internal medicine. What is it like caring for veterans?
This is the best job I've ever had in my life. And I think because it speaks to my sense of duty that I got from my parents, particularly from my father. And I really feel I got back to that, my original focus, which is helping people. So that sense of duty and serving those who served, which is our core mission, this job is the most rewarding I've ever had because you really feel like you're helping people.
How much do you learn about your patient's military history when you first interact with them?
It can come up in conversation. It sort of depends on what the context is and how much you ask and how much of that is incorporated into what's going on with their medical history. It comes up a lot in terms of particularly cancer because a lot of cancers that veterans develop can be related to their military exposures. So it can come up certainly in that context.
You write about how your patient and his wife brought in photographs of his younger self. Can you describe some of those photos?
So a lot of it was about the sports he was doing at the time. He was kind of almost like a bodybuilder and doing like martial arts. So there were some pictures of him in a shirt and shorts showing how healthy he was. He was much younger, but it was such a contrast to how he was at that time as he was nearing death. But it really rounded out my understanding of him because, as we all know, when we meet people, we see them when they're at that particular age, and we may not have that context of what they were 20, 30 years ago, but that still informs how they think about themselves. I mean, I still think of myself as an athlete, even though I'm much older. So that's important to understand how the patient thinks about himself or herself.
You know, it's funny, you mentioned those two photographs. I immediately flash into my mind, I had a patient who also was a martial arts expert. And I remember he was in his early 70s and hospitalized, but he made sure to put up that photo of him when he was in his prime in his martial arts outfit in a pose. And I've had another patient who was a boxer, and all he wanted to talk about whenever he saw me was his first experience boxing in Madison Square Garden and what that moment felt like of climbing into the ring, squeezing in between the ropes, and facing off in front of what must have been some massive crowd.
Yeah.
Why do you think it was important to them to bring in those photos to show you?
I think it was to help me understand what he had been. I think it was important for him because we had a relationship. It wasn't just transactional in terms of his medical problems. It was really conversations every day about what he was doing and how his life was going. And I think he really wanted me to understand what he had been. And so I felt really honored because I think that was important. It told me that his relationship with me was very important to him. I found that very, very humbling.
Yeah, I find it fascinating the details that patients offer to us about themselves as opposed to the ones that we solicit. I think it speaks to also the closeness of the relationship we have with patients when they want to share that aspect of them. They want to show you who they were before they were ill. And it's not a point of bragging, it's not flexing for them. I think it's really to remind themselves and us of the vitality of the person who's sitting in front of us or lying in front of us in the hospital Johnny or sitting on an exam table.
Oh, very much so. And I've experienced that even with my own parents as they got older and were in the medical system. I remember vividly my father had had a stroke, and the people taking care of him didn't understand what he had been. They didn't understand that his voice was very different. We kept asking, his voice is different. They had no concept of him beforehand. So that also really hit home to me how important it is to understand patients in the whole context of their lives.
And as a family member, do you think it's equally important to share that story of who somebody was before they were ill as a reminder to yourself and to the people taking care of a relative?
Oh, very much so. I think it's very helpful because it makes you feel like you're supporting the loved one as well by if they can't speak for themselves, particularly if they're very ill, to help people understand. It may help the physicians or any provider understand their illness better, especially if there's a diagnostic dilemma thinking about going home. What are they going to need at home? Those sorts of things. I think it's always important to try to provide that context.
Patients will often talk about their deaths or transitions to hospice as an abstract future. Do you think they rely on us to make the decision about a concrete transition to hospice? Or do you think they know it's time and are looking for us to verbalize it for their family and friends?
I think it depends on how much groundwork you've done beforehand. So when you talk about end of life with people well before that transition is almost mandatory, I think it's very important. It makes the transition much smoother because then they understand what hospice is and they can prepare themselves. When they're not prepared, I think it's much more of a very clear transition. So it's almost like you're shutting one door, disease treatment, and moving on to I'm just going home to die, versus when you're laying the groundwork and you make sure that it's about how you live. I always try to emphasize it's how you want to spend your time, it's how you want to live. Hospice is helping people live the best they can for as long as they can. And if you haven't prepared people, I think then they think much more you're closing the door and you're just sending me home to die.
It's tricky though, isn't it? Because as an oncologist or hematologist oncologist in our case, people look to us for that hope that there's still something to do and there's still life ahead of them. But at a certain point, we all realize that we need to transition our focus. But once we say that out loud, do you ever feel like it almost shuts a door for our patients?
Again, it depends on the situation and it depends on the support they have. It's different when you're dealing with somebody who's out in an outpatient world who has good family support and you've developed a relationship versus the patient who's taken a very sudden turn for the worse and maybe is in the hospital and things are more chaotic and maybe they've been on very active treatment beforehand, but suddenly things have changed. So in my mind, it depends on the context that you're dealing with and what the relationship you have prior to. And maybe you're covering for your colleague and you don't have a relationship with that particular family, with that particular patient, but yet you have to talk to them. Somebody gets transferred from another hospital and you have a very brief relationship. And so I think the relationship kind of dictates sometimes how patients feel. But as long as you can help people understand the process of end of life as best as you can, I think that sometimes helps the transition. Some people are going to be angry no matter what. And that's totally understandable. Angry about their family member dying, angry about what's happening to them if they're the patient. I think that's always part of the process, but it's hard to make things smooth all of the time. We do the best we can.
I was going to ask, has anyone ever been shocked when you start to talk about palliative care or hospice and never really did see it coming?
Oh, of course. I think, especially if you've been doing this for a while, you sometimes see the future. You know what's, well, I mean, not exactly, but you have a good sense of what's going to happen. And there can be times when you start talking about end of life and palliative care or hospice, and people are shocked, particularly family members who may not be there all the time, who may not have seen their loved one frequently and have understood what the disease course has been. And that certainly can be shocking. And again, totally understandable, but it's my responsibility to try to smooth that over and help people understand what's going on and make it a conversation.
It's a nice description of what we do. We make it a conversation. When talking about what you smelled that day, when you saw your patient, you write, "Did I suddenly have a gift? Could I float through the hospital wards and smell the future? Or maybe I could only smell inevitability." It's a beautiful sentence. Could I only smell inevitability? What do you think it was that led you to know that his time had come? And I wonder, was it a distinct odor or what I refer to as a Malcolm Gladwell blink moment, in which your 25 years of experience allowed you to synthesize 100 different sensory and cognitive inputs in a split second to realize this was the time?
I think I knew it was time because I had been seeing him so frequently and I knew him very well. The smell was very real to me. My husband and I disagree because I've talked to my husband about this. He thinks it was a real smell and that I did smell something. I think it was more that amalgamation of my experience. And as I said in the piece, a scent took the place of a thought.
Huh.
But it bothered me so much. And that's when I talk about Did I have a gift? There are people who can smell diseases. There's a report of a woman who could smell Parkinson's disease. I thought, have I suddenly developed some sort of gift? But in my mind, I thought, it was inevitability. I mean, it was inevitable that this gentleman was going to die of this disease. So that was my thought. I don't think I had a gift. I think it was smelling the inevitability that I understood through experience and knowing this patient so well.
Why do you think that smell haunted you so much afterwards? I mean, you really think about it and really dwell on it, I think, in a way that any one of us would.
I think because I thought there was something wrong with me. As I said in the piece, I thought it made my experience of that patient, my memory of that visit in particular, and the whole relationship with him, I was thinking more about myself instead of thinking about him and his experience and his family's experience. And, you always grieve for patients, and it was interfering with my normal process. And so it really bothered me. In the end, it was more, what was wrong with me? This was weird. And it just sort of played with my usual understanding of how these things were supposed to go. And that's what really bothered me.
It is true. We really feel acutely our patient's loss, and it's so much more, I don't know if acute is the right word, or so much more meaningful when it's someone we've gotten to know over years, isn't it?
Oh, very much so. You grieve for them, you miss them. At the same time, you also, especially with this patient, his death was how he wanted it. So helping someone with the quote unquote good death, the death surrounded by family, the death where there is no suffering or as minimal suffering as possible. You do find that helps in the grief, I think. Instead of thinking, oh, what did I do wrong? What did I miss? You can make it somewhat helpful in processing the grief.
It's perhaps one of the more exquisite aspects of the art of medicine is helping people with that transition in their final days and sharing in the emotions of that. It has been such a pleasure to have Alice Cusick, who is Hematology Section Chief at Veterans Affairs Ann Arbor Health System and Assistant Professor at the University of Michigan Division of Hematology and Oncology, to discuss smell. Alice, thank you so much for submitting your article and for joining us today.
Oh, thank you so much. I really appreciate it.
If you've enjoyed this episode, consider sharing it with a friend or colleague, or leave us a review. Your feedback and support helps us continue to have these important conversations. If you're looking for more episodes in context, follow our show on Apple, Spotify, or wherever you listen, and explore more from ASCO at asco.org/podcasts. Until next time, this has been Mikkael Sekeres for Cancer Stories.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.